Very good morning, doctors. So, welcome to a fresh session of surgery. So, we'll start with thyroid. So, previously we discussed all the surgical part of the surgical part of the breast. So, we will start with thyroid. So, we'll just start with the first session of thyroid. Okay. So, thyroid. What actually the thyroid is? Thyroid is a gland which is present anterior to the trachea, which is very much important for the maintenance of basal metabolic rate of the body. So that's the foremost and utmost single short line about thyroid. So let's dive into the real session, right? So thyroid, what is the normal weight of thyroid? The normal weight of thyroid is 100 to 125 or 130 grams. 100 to 125 or 130 grams. So that is the normal weight of the thyroid. So what is the actual anatomical presentation of the thyroid? Thyroid is actually present behind the trachea. But if you ask me what are the structures that are present, thyroid is actually present in front, anterior to the trachea. So what are the structures that are present behind the thyroid? That is trachea, behind the thyroid, that is trachea, recurrent laryngeal nerve, and esophagus. Now, what are the three structures that are present behind the thyroid? That is recurrent laryngeal nerve, trachea, and the esophagus. Now, what are the rings of trachea that are accessing parallel to the thyroid level? The rings of trachea that are parallel to the thyroid level are second ring, third ring, and the fourth ring. But the most important ring is the third ring, which is actually relatable with the isthmus of the thyroid. The third ring of the trachea is equally located parallel to isthmus of the thyroid. Now, if you ask me, what is the main component that is stored in the thyroid? In the thyroid, the main component that is stored is iodine. Now, if there is a deficiency of iodine, then it leads to formation of goiter. If there is a deficiency of iodine, it leads to formation of goiter. Now, in thyroid, nearly 90% of the iodine in the body is stored. 90% of the body iodine is stored in the thyroid itself. 90% of iodine. Now, if you ask me regarding the clinical status, who is denoted as the father of thyroid surgery? That is Theodore Hocker. Now, what is the relation between thyroid and the iodine? The weight of thyroid is inversely proportional to the iodine present. The weight of thyroid is inversely proportional to the iodine, total amount of iodine present in the body. That is the relation between iodine and the thyroid weight. Now, what are the syndromes that are related to the thyroid? Some of the syndromes which are actually relatable with the thyroid are Pendred syndrome and Repetov syndrome. Pendred syndrome and Repetov syndrome. What is meant by Pendred syndrome? What are the features that are observed in the Pendred syndrome? Pendred syndrome, generally the patients who are affected with Pendred syndrome, they present with congenital sensory neural hearing loss with goiter. That is defined as a Pendred syndrome. And what is the genetic component of the Pendred syndrome? That is chromosome 7q, right? The long arm of chromosome 7q, that is the genetic component of the Pendred syndrome. Now, what is Repetov syndrome? In Repetov syndrome, the patient presents with end organ resistance to the T4. End organ resistance to the T4 means even though the T4 hormone is if it tries to go on and activate with it, still it doesn't activate. So there is an end organ resistance to the T4. Now, what happens? Obviously, if there is a resistance to the T4, then obviously there will be signs which are related to hypothyroidism. So the patient present with the signs and symptoms of hypothyroidism. That is very important about Repetov syndrome. Now, there are two effects that are very much important according to the NEET PG examination. You will be getting some questions from these effects definitions. What are the two effects that are seen in related to the thyroid? One is Wolff-Chakoff effect and another one is Jod-Basedow effect. What is Wolff-Chakoff effect? Wolff-Chakoff effect means the condition where the iodine induces to produce hypothyroidism. If there is the presence of iodine induced hypothyroidism, then that effect is called as Wolff-Chakoff effect. If there is a presence of iodine induced hyperthyroidism, then that is called as Jod-Basedow effect, or it's also called Jod-Basedow phenomenon. Jod-Basedow phenomenon, right? Now I think you are clear with the effects and syndromes. Please, Pendred syndrome. Pendred syndrome is very important for INA-CD. You might get a question on Pendred syndrome. Pendred syndrome is congenital loss of sensory neural hearing loss with presence of goiter, and it is due to genetic variation in the chromosome 7q position. And Reftoff syndrome is something, there is end organ resistance to the T4. Due to resistance to the T4 hormone, obviously there is an exhibition of signs and symptoms which are related to hypothyroidism. Okay, so that is about Reftoff syndrome. Now there are so many disorders. Which are related to the thyroid, but in all those disorders, what are the most common congenital disorders of the thyroid? One of the most common congenital disorders of the thyroid is thyroglossal cyst. Thyroglossal cyst. Now, so many doctors may get a question or may get a doubt like, why SAR did not place image here? Why I did not place image here? Because there is a reason. I want to take 2 minutes of your time, because I am just thinking that most of you have finished the first complete study. The first general study of all the topics were done, I think so. Even some of the students, they might have started the first revision also. So I am not showing the images here, because I want you to just revise and remind the images inside your mind when I am about to talk about the topics here. So you just try to recognize all the images inside your mind so that you can easily revise and remember without any problem. If I try to show everything here itself, then there is no point of revising and there is no point of learning with me. So if you have ever seen a thyroglossal cyst image, then you can easily remember. Your mind will just recollect those images, but no problem. Don't feel anything sad. We have a image session. Obviously, in the image session, I will be dropping nearly 800 to 1100 images. So don't get panic. Please be still. I will just go on with the session itself, right? So thyroglossal cyst, it's one of the most prominent congenital disorders of thyroid that we ever see in our day-to-day clinical practice also. So even though thyroglossal cyst is a congenital anomaly, but still the presentation will be at 15 to 30 years of age only. Even though it is a congenital anomaly, the presentation of TG cyst is at 15 to 30 years only. Okay. Now, what is the presentation? What is the most common complaint that you will observe? There is a midline swelling at the anterior part of the neck. There is a midline swelling at the anterior part of the neck. For example, if there is a if this is a neck, then here you will have a swelling. This is a, see, this is jaw. This is jaw. Okay, this is jaw. This is jaw. Here your lips are there. You just extended your head. It's in a fully extension of head. Now here in the midline of neck, this is midline of neck. Here there will be thyroglossal cyst. Here. Now what actually is a thyroglossal cyst? Actually, if you go into the embryological conditions of the thyroid as embryology of the tongue, then you got to know a feature called thyroglossal tract. That is a thyroglossal tract or thyroglossal duct. For example, if there is a remnant of the things which actually should disappear in the going on with the development, if there is a remnant that is being present there, then obviously it turns into a thyroglossal cyst. So thyroglossal cyst is something which is related to a tract that is present in between tongue and the thyroid. So that is why it is given with a name called thyroglossal cyst. Thyro means thyroid, glossa means tongue. You all know that, right? Now, what is the bone that is present in relation to the thyroid? For example, if this is a thyroid, then at the back of it, behind the thyroid, you will have a bone that is hyoid bone. So the bone that is present in relation to the thyroid is hyoid bone. Now, what is the most common location of the thyroglossal cyst? It is subhyoid. Always remember, the most common location of thyroglossal cyst is subhyoid, or you can also call it as infrahyoid region. Now, what is the most detonating feature of thyroglossal cyst? If you ask the patient to protrude his tongue, obviously there will be a movement of the cyst with the protrusion of the tongue. That is called as deglutination. So the thyroglossal cyst, it moves with the deglutination. Now, what are the complications of the thyroglossal cyst? The most common complications of thyroglossal cyst is formation of abscess. Formation of abscess. Now, what will we do if the patient complains with abscess? We will just incise and we will drain, right? We will just incise the abscess and we will drain the abscess. Further, after the incision and the drainage of abscess, it leads to even more dangerous complication, that is thyroglossal fistula. Thyroglossal fistula. Remember, thyroglossal cyst is a congenital condition, whereas thyroglossal fistula is a acquired condition. Very, very important. Thyroglossal fistula is a acquired condition. How it will get? If the thyroglossal cyst complicates to form an abscess, that abscess, if it is incised and drained, then that may lead into a complication called thyroglossal fistula. Now, if the thyroglossal cyst, if it is for a long standing period of time, if the thyroglossal cyst remains for a long standing period of time, then it leads to an increased risk of papillary carcinoma of thyroid. Now, I want to ask you a question here. What is the most common form of carcinoma seen in thyroid? And the second question is, what is the most dangerous carcinoma in thyroid? Please put it in the comment section. What is the most common form of carcinoma seen in thyroid? And what is the most common form of thyroid carcinoma which is dangerous with worst prognosis? Please put it in the comment section, right? Now, getting on with the rest of the word. Now, what is the treatment for thyroglossal cyst? What is the treatment for thyroglossal cyst? See, what happens is, this is the cyst, this is the tract. Here there is a formation of cyst, right? Here there is a formation of cyst. Now, we already explained that the hyoid bone is relatable with the thyroid part, right? The hyoid bone can be related with the thyroid level. So this is the hyoid bone. This black one is the hyoid bone, right? Now this is the tract. See, this is all the tract, and here there is a cyst. Now the cyst is continuing from the central portion of the hyoid bone. See, this is the central portion of the hyoid bone, and the cyst is in continuity with the central portion of the hyoid bone. Now, if you want to remove the cyst, we should also remove the central part of the hyoid bone. Now, that procedure is called cyst trunks operation. Now, what is cyst trunks operation? The en bloc removal of cyst with mid portion of the hyoid bone. That is called as cyst trunks operation. Remember, that is called as cyst trunks operation. I think one of the point we missed. No, we finished in there. Okay, so that is called as cyst trunks operation. Now we will come to one of the most common condition of thyroid we mostly see in hilly areas in India. Why? Because due to deficiency of iodine. What is that condition? That is goiter. Most commonly seen in who? It is most commonly seen in females. Always remember, thyroid related disorders are most commonly seen in females. Always remember, thyroid related disorders are most commonly seen in females. Now coming to the goiter, always we heard about a name called endemic goiter, but what actually is meant by endemic goiter? For example, there is a population. If more than 5% of that population are having goiter, then that region can be said like it is affected with endemic goiter, or they can be said like there is a presence of endemic goiter in that particular region if more than 5% of the population have goiter, right? Now we will discuss something about one of the most common forms of goiters that are seen, that is called as retrosternal goiter or substernal goiter, or we can also call as mediastinal goiter. What is a retrosternal goiter? For example, this is a rib cage, here is the opening. If the 50% of the thyroid tissue is present behind the rib cage, or 50% is more than 50% of the thyroid tissue, if it is located below the opening of thoracic cage, see this is thoracic cage, this is the thoracic cage. If 50% of the thyroid tissue is like this, then that can be explained as a retrosternal goiter. I will just draw a diagram here, then you can understand. Right? For example, see, this is a thoracic cage, right? See, this is a sternum. This is a sternum. This is a sternum. Okay. Now, if 50% of the thyroid is present below the opening of the thoracic cage, if 50% is more than 50% of thyroid tissue located below the opening of the thoracic cage, then that is defined as a retrosternal goiter. Now, majority of the goiters are asymptomatic. Why? Because their size is almost small. So, obviously, majority of goiters are asymptomatic. Now, previously we will discuss what are the three structures that are present behind the thyroid. One is trachea, another one esophagus, and another important thing is recurrent laryngeal nerve. So, these are the three structures. You can remember it with the mnemonic TER, TER, trachea, esophagus, recurrent laryngeal nerve. If trachea is compressed due to the growing size of the goiter, then it leads to dyspnea. Now, dyspnea is the most common symptom that is exhibited or explained by the patient, and it is mostly pronounced during the night time only. The patient complains like, I have difficulty in breathing during the night time, I don't know why. He will say like that. So that is the most common symptom which points it out to goiter. And which type of goiter? Retrosternal goiter, mostly. Now, if the goiter compresses the recurrent laryngeal nerve, then the patient exhibits a hoarseness of voice, or also called as dysphonia. If the goiter compresses the esophagus, it exhibits with a dysphagia, difficulty in swallowing. Now, with all this, the patient in his anterior chest wall, there will be some dilation of veins. On the anterior chest wall of the patient, the veins appear like they are dilated or engorged. Dilated veins appear on the anterior chest wall of the patient. That condition occurs due to formation of collaterals. Why due to formation of collaterals? Because the goiter, which is increasing in size, it compresses the surrounding or the adjacent tissues, thereby leading to inhibiting the blood supply or vascular supply. This leads to formation of a collateral formation. Now, what is the most important sign that we see in the goiter patients due to presence of these dilated veins? See, that is a sign called Pemberton sign. The Pemberton sign. What is that Pemberton sign? You ask the patient to lift his both upper limbs. You just ask him to lift those both upper limbs above the forehead. You ask the patient to lift his two upper limbs above the forehead. When he lifts the both upper limbs, right hand and left hand above the forehead, there will be an exhibition of facial puffiness as well as facial congestion. The facial congestion appears like a redness, as well as there will be a presence of facial puffiness. This is called as Pemberton sign, which is positive in case of goiter patients, right? So we say that Pemberton sign is positive in case of goiter patients who has a large size goiter. We are not talking about small size. Small size are actually asymptomatic. So that is the reason previously we discussed a statement like most of the goiters are asymptomatic. Why? Because the goiters are small in size, right? So Pemberton sign positive can only be seen if the goiter is large or if it is very big size. Then only you can see the Pemberton sign positive. Now, what is the treatment? What is the treatment if there is a goiter patient, right? So we simply do something called, if there is a retrosternal goiter, if the patient presents with a retrosternal goiter. We already discussed what is meant by retrosternal goiter. 50% of the thyroid tissue which is present below the opening of rib cage. It's not rib cage. You just say it like body cavity. So 50% of the thyroid tissue which is present below the opening of thoracic cage, or you can also say rib cage. Yes, obviously, see, every structure in the so-called trunk is present in the ribs. So what is the problem in it? Obviously, it should present inside the ribs only, na? So that is called as retrosternal goiter. Now, what is the treatment in case of retrosternal goiter? So the treatment is very simple. You go for thyroidectomy, in which the incision is done at the cervical region. That means at the neck region. The incision is done at the neck region. Here the incision is done. This is neck, and here we will give the incision. Now, why we will give the cervical incision? Any reason? Because the vascular supply for the goiter is mainly from the vessels that are from the cervical region only. So we will give a cervical incision only during the thyroidectomy. Okay. So the vascular supply is mainly from the vessels that are from the cervical region. So that's why we do a thyroidectomy with cervical incision, right? We'll go on with the next continuous topic. So 1 minute. Yeah. So that is all about the surgery. Now, how will you diagnose or how will you investigate a goiter, be it retrosternal goiter or any other swelling present in the thyroid? What is the main source of investigation? We do something called radioactive iodine scan. We do something called radioactive iodine scan, or it can also be called as thyroid scan. It's called thyroid scan. So what are the two radioisotopes that are used during radioactive scan? The first one is iodine 131 and the second one is iodine 123. What is the importance of iodine 131 and what is the importance of iodine 123? So we will learn it here. So iodine 131, it actually has a half-life of 8 days. So if it has a more half-life, now just think logically with common sense. If a compound has more half-life, can it be used for therapy or can it be used for diagnostic? See, diagnosis is something which we do only instantly. We don't want to do the diagnosis for days and months, right? Diagnosis is the done, we do it for instantly. We want to diagnose instantly. So we want a short half-life compound for diagnosis purpose. But if for therapy, therapy is something which we do for days, months, even sometimes for years also. Yes, sometimes for years also we do some therapy. So in both of these, iodine 131 and iodine 123, iodine 131 has more half-life, 8 days. So it can be used for therapy, and it is mainly used for therapy. Whereas iodine 123, if you speak, it has a less half-life, only 13 hours, very short half-life. So it can only be used for, and it can mainly be used for diagnostic, not only, it's mainly used for diagnostic because it has half-life very shorter, that is 13 hours only. So it can't be used for therapeutics that much efficient. But if you come to iodine 131, it has 8 days of half-life, so it can be used for therapeutic mainly. Now, can we use iodine 131 for diagnostic? Yes, you may use, but if it has more half-life, 8 days, so it may cause some serious side effects. So everything has its own benefit. Okay. Now we understood that radioisotopes do some job. Now, how do they do their job? What is the main mechanism behind that? See, these radioisotopes emits two rays, beta rays and gamma rays. Now, these beta rays, they are exhibited nearly 90% of the total rays that are emitted. So, beta rays are 90% of the rays that are emitted from the iodine isotopes. 90% are beta rays only, and 10% are gamma rays. This is a MCQ. Remember, this is a MCQ. So 90% of the total emitted rays are beta rays, 10% of the emitted rays are gamma rays. Now these gamma rays are responsible for tracer studies. These gamma rays are used for the tracer studies. These are actually the helping compounds for tracer studies, that is diagnostic. These beta rays are the main compounds for, main rays that are helpful for therapeutic purpose. These beta rays are responsible for therapeutic purpose, that is one thing. Now, gamma rays actually have some side effects. We already know, we studied in final years, so we know that gamma rays are responsible for side effects. Why? Because these gamma rays, they are emitted at least for 8 days in significant amounts. These gamma rays, are responsible for the side effects because they are emitted at least for 8 days in significant amounts, right? So, having the lots of side effects, these gamma rays are absolutely contraindicated for radioactive iodine ablation, right? So these gamma rays, as they are having lot of side effects, so radioactive iodine ablation is absolute contraindication regarding two features. That is, one is pregnancy and another one is lactation. Why radioactive iodine ablation is very importantly contraindicated in pregnancy? Because in pregnancy we have fetus in the fetus present in the women. So obviously, if this radioactive iodine is exposed to the pregnant women, obviously this radioactive iodine may affect the fetus. This radioactive iodine may affect the fetus, and it may cause some serious damage and consequences that are brought in the developing fetus. So the radioactive iodine ablation is highly contraindicated in two conditions, that is pregnancy and lactating women. Even lactating women also, radioactive iodine ablation is highly contraindicated. Now the radioactive iodine uptake is actually what? It is the amount of radioactive iodine which is taken by the thyroid within a span or stipulated time of 6 to 24 hours. 6 to 24 hours, right? For example, if your giving a radioactive iodine to a patient who is suffering with retrosternal goiter, it is the amount of radioactive iodine that is taken by the thyroid within a stipulated time of 6 to 24 hours, right? Now, we will discuss something about radioactive iodine. Now, how a radioactive iodine scan shows the anomalies. I mean, the abnormalities in the thyroid. How the radioactive iodine shows the abnormalities in the thyroid. For example, if the radioactive iodine scan is done with a so-called a normal patient, for example, if a radioactive iodine is given to a normal patient, so what you see is, wait, I will draw with a pen. So this image is also, yes, it will be given in the image session. Don't get panicked. Okay. So for example, if there is a thyroid, so what happens is you just see the so-called the deposits of this radioactive isotope, that is called as radioactive uptake, radioactive iodine uptake. You see a complete radioactive iodine uptake in the complete thyroid glandular tissue. There is no deficit, there is no imbalance like that. So it's just seen in a normal scan. But if you see, like for example, there is a thyroid. Wait, just 1 minute. I'll draw it neatly. So there is thyroid. For example, this is a thyroid, and if you see at some part of the thyroid scan, there is the excess uptake of radioactive iodine. For example, there is the more amount of radioactive iodine uptake is there rather than the normal uptake, then it depicts that there is a hot nodule present in the thyroid gland. It depicts that there is a presence of hot nodule at that particular tissue of the thyroid, that is called as hot nodule. You just observe that there is an increased amount of radioactive iodine uptake. Whereas in some other conditions, what you see is, for example, this is a thyroid. In some other conditions, what you see is, you simply see there is a decreased uptake. See, this normal tissue, this thyroid tissue, completely you are having radioactive iodine uptake. But if you see here, see this tissue, it is devoid of radioactive iodine uptake. There is a decreased radioactive iodine uptake. Now that is what called as cold nodule. That is called as cold nodule. See, very important guys, because these type of scenarios, they will be given in a clinical MCQs. These will be given directly in a clinical MCQs, and trust me, see, we have an image session. Even thyroid scans also, I will show something like we have 36 thyroid scanning images in our data. So we will show those 36 scanning images. You have all the thyroid anomalies regarding their scans, everything. So in the clinical image session, I will explain it even more deeper. But see, in the MCQ itself, you will get the image. Which image? You will get the radioactive iodine scan, that is also called thyroid scan. See, both are one only. RAI scan and thyroid scan are one only. Please, doctors, don't confuse. Both are same. Radioactive iodine scan and thyroid scan, both are same. Don't confuse, right? In the exam, you will be confused, like thyroid scan is done in the so-called patient, 23 years old female who is actually a pregnant female. So pregnant female, it's highly contraindicated. It's a normal female. Maybe she is a postnatal after 1 year. So you'll get some tricky questions. The examiner will ask you, she is a postnatal mother. Normal vaginal delivery has occurred 1.5 years before. That is postnatal 1.5 years. That is 18 months postnatal mother. Now, what is your treatment of choice? Now, when the question was given with postnatal mother, most of the students will get confused. Oh my God, she is a postnatal mother. Now the complete criteria changes. No, nothing changes. Nothing changes. Don't get confused. See, only in pregnant women and lactating women only, any surgery or some other protocols will slightly change. But rest of all conditions, they have normal protocols only. You don't need to bang your heads and make yourselves confused, right? So that is called as cold nodule, right? So there will be a decreased uptake of radioactive iodine. Now, is there any problem with hot nodule and cold nodule? Of course, these hot nodules and cold nodules, they may lead to changes that convert the normal state to malignant state. That may lead to a malignancy. Now, what is the risk of malignancy in case of cold nodule? In case of hot nodule, we'll first discuss. In case of hot nodule, the risk of malignancy is 1 to 3%. But in case of cold nodule, the risk of malignancy is 17 to 20%. See, even though cold nodule appears chill, relax, but still its malignancy is very high, 17 to 20%. So don't think like just because it was given with the name cold, it doesn't cause any malignancy. Just because it was given with the name hot, it is very rapidly. No, 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 no. Hot nodule has less chances of risk of malignancy, whereas cold nodule has high chances of risk of malignancy, 17 to 20%. Now this is very important statement. It can be given in INICet. Very important. Please remember. Okay. Now coming to the next conversation, we will discuss some points about one of the important disorders and most of the important disorders of thyroid. Now the first one is Graves' disease. What is Graves' disease? In Graves' disease, what happens is when you conduct radioactive iodine scan, there is a diffusely spread increased uptake of radioactive iodine. You won't get only a regional increase uptake. You will get a diffused. That means most of the thyroid tissue, there will be a increased uptake of radioactive iodine. So it's a diffusely arranged increased uptake of radioactive iodine. That is seen in Graves' disease, right? Now, here we will show the image in Graves' disease. Yes, we will show in the image session. Don't see. If I want to keep, I will keep the image. Don't think like sir has just left empty. No, it is for your benefit only. You should revise some things. You should remember some things. You should recall some things. So exam is all about revise, recall, and remember. And these remembered information you should vomit. Vomit where? You should vomit in the exam. Or in other words, you can say you puke. Just puke in the exam. So what is our strategy? R. Revise, recall, and remember. Triple R. Okay, not. Okay, so let's get into the topic again, right? So that is Graves' disease, right? So what is TMG? Toxic multinodular goiter. Multinodular. The name itself denotes you have multiple nodules. Multiple nodule means either one type. No, you can have both types, hot nodules and cold nodules. Cold nodules have increased risk of malignancy, that is 17 to 20%. Remember, very important. Okay, so in toxic multinodular goiter, you see both hot nodules as well as cold nodules are seen. Now hot nodules in the toxic multinodular goiter, it appears black. Why it appears black? Anyone? It's not black, it appears dark. You should say dark. Dark is different from black. Dark. See, in X-ray you see dark areas, opaque areas. Yes, you see it, opaque areas. So hot nodules, they are visible dark. Why they are dark? Why they are dark? Because hot nodules, they have increased uptake of radioactive iodine, so they appear dark. Cold nodules appear white. Why? Because cold nodule has decreased uptake of radioactive iodine, so they appear white. Okay. Now we come across one more important condition, that is called thyroiditis. Any name which ends with itis means inflammation. Remember, appendicitis, colonitis, ulcerative colitis, esophagitis, gastritis. So anything which ends with the name itis or with the itis word, then it is inflammation. So thyroiditis means inflammation of thyroid with the destruction of the follicles. That is defined in the thyroiditis. And if you do radioactive iodine scan for thyroiditis patient, there will be decreased radioactive iodine uptake. Now, can you tell me, if there is inflammation, then inflammation is something like, you can define it as hot. Now, if it is a hot component, there should be increased uptake. But in thyroiditis, why there is decreased uptake? Common sense. Always use your common sense. Here thyroiditis, there is inflammation as well as follicular destruction. See, there is a destruction of the tissue. The radioactive iodine uptake is done by tissue only. But if the tissue itself is destroyed, who will cause the radioactive uptake? No one will be there to absorb the radioactive iodine. Now, if there is no one to absorb the radioactive iodine, obviously the uptake will be decreased, right? Understood or not? For example, you have stomach. I just resected the stomach as well as the intestines also. Now, I will just given you the food. Now, will the food will be absorbed? No. Why? Because stomach as well as intestines both are resected. So, you cannot absorb the food. Obviously, you cannot absorb the food. So, food can't be seen in your stomach because there is nothing to absorb there. There is no viscera or no organ to absorb the food which is eaten. So, like that, if the follicles of the thyroid are destroyed due to the inflammation, there will be no thyroid tissue left for the radioactive iodine uptake. So obviously there will be decreased radioactive iodine uptake in thyroiditis. Now, sometimes the uptake can be hardly, is something like even less than 5% also. See, that means that much of destruction will occur. Even nearly 95% of the thyroid tissue may be destroyed due to this inflammation. So you can see an uptake of only less than 5% in some rare cases in thyroid. So that is the severity you might observe in thyroid. Now, what are some of the surgeries which we conduct normally regarding thyroid conditions? You have three main forms. It's total thyroidectomy, hemithyroidectomy, and subtotal thyroidectomy. Now, coming to the total thyroidectomy, you will completely remove the whole thyroid tissue present at that region. That is called total thyroidectomy. What is hemithyroidectomy? You will remove one complete lobe plus you will remove the isthmus also. This is called as hemithyroidectomy. So entire one lobe with isthmus is being removed. Now what is subtotal thyroidectomy? You will completely remove most of the thyroid tissue, but you will leave 3 to 4 grams of thyroid tissue on each lobe. You understand or not? Most of the thyroid tissue will be removed, but nearly 3 to 4 grams of thyroid tissue will be left on each side. See, these two little thyroid tissue on each side are left. These are retained regions of thyroid tissue. Rest all, see these red lines, rest all this tissue is removed. Okay, now that is called subtotal. Now there is one more which is a modified subtotal thyroidectomy, that is called Hartley-Dunhill procedure. It is actually a modification of subtotal thyroidectomy where 4 to 6 grams of thyroid is left on each lobe. That is also called as Dunhill procedure. Now you might ask me, sir, why we should learn all these procedures? Why? Because in the exam you might be given with this image, or you might be given with a something like it's a history of, wait, I will tell you. You might be given with a history of 24-year-old female came with a complaint of intolerance to heat, and she is having palpitations, tachycardia, and she is also having a weight loss, severe weight loss, and she is also having some tremors, fine tremors, not coarse, fine tremors, right? So she is complaining of all sympathetic complaints. She is complaining of all morphological related complaints. So she was undergone with the below surgery. The diagram was given, and the diagram will be like this. What is the type of thyroid surgery done? Total, hemi, subtotal, Dunhill. So if this was given, you should mark subtotal as the answer. See, these are actually simple questions you get in NEET PG. The only thing you have to just point it out is common sense, little bit of common sense. Don't complicate things, right? Going beyond the line, revising all. See, you revise the notes, that will be sufficient. Don't bang your head into unnecessary information. This is all necessary. These all images are necessary. These will be given as MCQ. These will be given as image questions. So these all are necessary information. Don't go into unnecessary information. Okay. Now we discussed about Dunhill procedure. Now what is meant by near total thyroidectomy? Near total thyroidectomy means we will leave 1 gram of thyroid tissue which is present adjacent to recurrent laryngeal nerve and near to the ligament of Perry. That is called as near total thyroidectomy. I will show you one image also. See, these all are drawn images, but don't think like I will not show images. Yes, I will show you images in the image session. See, this is the thyroid. This is the recurrent laryngeal nerve, right? And here you will have a ligament of Berry, right? And this one is the part of the thyroid tissue that is retained. So except this tissue, rest of the thyroid will be removed, except this tissue, small tissue which is present adjacent to recurrent laryngeal nerve, right? So that is called near total thyroidectomy. Okay. Now coming to what are some of the criteria that you can remember for surgery selection, means whether you should go for hemithyroidectomy, whether you should go for total thyroidectomy, whether you should go for subtotal thyroidectomy. So what are some of the criteria that you should remember? For example, if the patient has only one lobe affected, if the patient's thyroid, in which only one lobe of the patient's thyroid is affected, you simply go for hemithyroidectomy. If the patient is being diagnosed with thyroid malignancy, you go for total thyroidectomy. But if the patient is diagnosed with a benign disorder which is present on both lobes of the thyroid is being affected with a benign disorder, you go with total thyroidectomy. Okay. Now, if the patient present to you with multinodular goiter, then what you should do? See, I will just explain a small concept here. Don't think like I am wasting your time, but just please listen to this small concept. Very important. Very, very important. Don't think like it is unnecessary, but very important. Yeah. So, for example, it is thyroid. In multinodular goiter, you have hot nodules, you have cold nodules. So you will have multiple nodules, right? Hot nodules, cold nodules. Now, for example, if you try to do some resection procedure, like see something like saving the thyroid tissue. That means if you do subtotal or if you do hemithyroidectomy, what happens is this tissue, I will just draw in color, this tissue which is left, this tissue which is done as a remnant, this remnant tissue, they might trigger and they might increase the chance of recurrence. So even though if you have a desire to preserve the thyroid tissue, but that retained tissue might further, again after some time, it may cause recurrence of the abnormality again. So that is why rather than going for thyroid tissue saving surgeries, you just simply do total thyroidectomy. Why? Because if you left some tissue, if you leave some tissue, if some tissue is retained in the part of surgery, as a part of surgery, that retained tissue might increase the chance of recurrences. So that is why always prefer total thyroidectomy in case of multinodular. And one more thing, and one more benefit is, if you do total thyroidectomy, the only thing you have to do in the follow-up is levothyroxine therapy. Levothyroxine therapy you have to do for lifelong in order to supplement the thyroid hormone. But if you just simply leave some tissue by doing a hemi or subtotal, that will lead to causes of recurrence of multinodular goiter again or goiter again. Again you have to do surgery. Again there will be recurrence. Again you have to do surgery. Again there will. So rather than going for recurrence itself, it's better to go for total thyroidectomy. So it is easier to manage a patient on levothyroxine rather than recurrence, which is dangerous. Why dangerous? Because you have to do surgery again and again and again and again. Look so on, right? Then, if see, we discussed about total thyroidectomy, we discussed about hemithyroidectomy. Now, if total thyroidectomy is done somewhere and hemithyroidectomy is done somewhere, then where will we do subtotal thyroidectomy? See, if one procedure is there, obviously it should be done somewhere. See, if side effects are there, anything, but somewhere you should do that procedure. Somewhere you should give that procedure a chance. So what is that condition? So subtotal thyroidectomy, it is done in multinodular goiter, but only in case of elderly patients, not in younger patients. I am saying once again, only in elderly patients who are suffering with multinodular goiter, only in them you will just go with subtotal thyroidectomy. But rest all patients with multinodular goiter will go with total thyroidectomy. Okay. Now we will discuss something about solitary thyroid nodule. Very, very important for INICET. Very important topic. Solitary thyroid nodule. Now, what is the most common form of solitary thyroid nodule? Colloidal goiter. Prominent than follicular adenoma. Colloid goiter, which is the most common form of solitary nodule thyroid, followed by follicular adenoma. Okay. Now, how will you investigate the solitary thyroid nodule? The first investigation that is done for solitary thyroid nodule is thyroid function tests. Now, what are the components of thyroid function test? It is T3, T4, TSH, right? Why TSH is the most informative? Because TSH has a ultra sensitivity feature. That means even a little bit positive can easily be detected. So that is why, due to ultra sensitivity feature of the thyroid stimulating hormone, it is the most informative marker in the thyroid function test. You have three things, that is T3, T4, TSH. Out of TSH is the most informative. Now, what is the investigation of choice? Not first investigation. First investigation is thyroid function test. But what is the investigation of choice? That is FNAC, fine needle aspiration site. But there are some limitations for the FNAC. You can't do FNAC blindly because you might be dealing with follicular neoplasm or neoplasia. You might be dealing with Riddle's thyroiditis. You might be dealing with thyroid lymphoma. So obviously FNAC has some serious limitations. That is follicular neoplasm or neoplasia, Riddle's thyroiditis, and thyroid lymphoma. Now, what investigations then you will do in these three conditions? Follicular neoplasia, Riddle's thyroiditis, and thyroid lymphoma. You will simply go for biopsy. Biopsy is the investigation of choice in thyroid lymphoma. Okay. Now, why FNAC cannot be done in neoplasia? Why? Because FNAC actually it cannot differentiate adenoma from follicular carcinoma. See, neoplasia is a type of carcinoma, cancer. So, FNAC cannot help you in differentiating adenoma from follicular cancer. So, FNAC cannot be done in follicular neoplasia because the diagnosis of follicular cancer or carcinoma is based on vascularity invasion or capsular invasion. So, if the diagnosis is based on vascular or capsular invasion, what is the point of doing FNAC? Because FNAC cannot detect those features. Only biopsy can do those things. So, diagnosis of follicular neoplasia or the investigation that is done in follicular neoplasia or neoplasm is biopsy, as well as Riddle's thyroiditis. Why FNAC cannot be done? Because in Riddle's thyroiditis, the complete thyroid as well as the parathyroid tissue is replaced with fibrous tissue. So you cannot do FNAC, and FNAC cannot be done successfully in Riddle's thyroid. And thyroid lymphoma, obviously the investigation of choice is biopsy. Okay. So we'll get on with the rest of the things. I think until here it's clear for you, right? There is no doubt. Okay. Until here it's clear for you. Now we will discuss the clinical features, the investigative procedures for solitary nodule. Now we will discuss what is the management of solitary thyroid nodule. Obviously the investigation of choice is FNAC, but we already discussed FNAC has some limitations. That is, if it is follicular neoplasia or neoplasium, or if it is Riddle's thyroiditis, and if it is lymphoma, you should go for biopsy rather than FNAC. But investigation of choice for solitary thyroid nodule, obviously it is FNAC. Okay. Now, when we do FNAC in a patient, generally you might get four results. Four types of results you might get, right? You might get a result of inconclusive, or you might get a report of benign, or you may get a report of suspicious, or you might get a report of confirmed malignancy. For example, if the FNAC report says it is inconclusive whether the patient has any changes or not, then simply you go for repeat FNAC. You again repeat the FNAC. But FNAC report came like the patient is having a benign condition, and if it is being confirmed in the FNAC that the patient is having a benign condition. Now that benign condition, it can be solid or cystic. If that benign condition is a cystic type of condition, you simply do aspiration, and this aspiration regarding that cystic condition, it can be done maximum of 3 times. So you can reaspirate, reaspiration can be done for a maximum of 3 times. But even after doing the reaspiration for that cyst, even for more than 3 times, still the recurrence is coming, then you simply go for total thyroidectomy. During the investigation of FNAC, if the report came like the patient is having a benign condition, You check whether it is solid or cystic. If it is cystic, you simply go for aspiration. If you want to repeat the aspiration after some time, again you repeat the aspiration, you re-aspiration, like that. You can re-aspirate the cystic component maximum of 3 times. But if the fourth time, again, if the recurrence is there, you simply go for hemithyroidectomy. You simply do hemithyroidectomy. Okay. Now, if it is a solid component, it's not cystic component, it is solid component, then what you will do? You will simply give thyroxine, levothyroxine, or some thyroxine supplement you will give. But even though after giving thyroxine for a couple of months, still the patient is not responding, you simply go for hemithyroidectomy. So ultimate climax is hemithyroidectomy. You simply remember like that. Benign condition, ultimate climax is hemithyroidectomy. If it is cystic, go for reaspiration. Recurrence is there, go for hemithyroidectomy. If it is solid, go for thyroxine therapy. If there is no response, you go for hemithyroidectomy. As simple as that. Now, if the FNSA report came like there is a suspicious changes for malignant, suspicious, not confirmatory, suspicious, then you check with radioactive iodine scan is done. If the radioactive iodine scan came like there is a presence of old nodule, you simply go for hemithyroidectomy. Previously, we already discussed, right? Previously, we already discussed. You have a nodule, you resect here. Hemithyroid. This is hemithyroidectomy. This part you will do. You understand now what is hemithyroidectomy? You will remove this part. Isthmus plus one complete lobule. That is hemithyroidectomy. Okay. So if it is a cold nodule, you remove hemithyroid. You do hemithyroidectomy. If it's a hot nodule, also you do hemithyroidectomy. Or you can also do radioactive iodine ablation. Now some doctors will get a doubt. Sir, can radioactive iodine ablation cannot be done in cold nodule? Yes, it cannot be done. Why? I always say one thing. Common sense. Use your common sense. Why it is called cold nodule? Because there is decreased uptake of radioactive iodine. Why there is decreased uptake of radioactive iodine? Because there is a decreased transparency. Obviously, there is a decreased uptake of radioactive iodine. Now, if there is decreased uptake of radioactive iodine in cold nodule, then how you will do radioactive ablation? If the tissue not at all absorbing the radioactive iodine, then what is the point of conducting the radioactive iodine ablation? So you cannot do radioactive ablation in cold nodule, right? So I think you understood that one. If you have finished it, we'll just go to the other topic. We'll just go to the other topic, right? Now, regarding the cytopathology of the thyroid, a system has been designed so that depending on the cytopathology of the thyroid, we can easily classify into categories. For example, we are unable to diagnose what actually it is. So it is non-diagnosable condition. So it is categorized under THY1. Right? Now, we have recognized it as a cystic condition, but we are unable to diagnose it perfectly. Then it is designated under THY1C. Now, UV confirmed that there is no presence of neoplasia. It is non-neoplastic. It is confirmed like the solitary STN is non-neoplastic. Then you can designate it with THY2. Now you just confirmed that it has the STN condition. Solitary thyroid nodule is presented with follicular neoplasm report. then you can categorize it with Th by 3. If there is suspicious for malignancy, it is Th by 4. If you have confirmed the lesion as malignant, it is Th by 5. Okay. Now that is up to the Bethesda classification. Now if someone asks you what are the functions of thyroid hormone, I think you all know. No need to explain all those things. You can just revise it from the very own physiology, medicine, whatnot. Every subject will have thyroid chapter. So you revise from there. Basal metabolic rate conversion, functional metabolic rate, cellular metabolism regulation. Every function is being helped by the thyroid gland. Now, if you ask me a direct statement, what is the most common cause of hypothyroidism? It is obviously Hashimoto's. Then what is the most common cause of hyperthyroidism? It is Graves' disease. Graves' disease. Now we will discuss what is Graves' disease. Graves' disease also we can call it as diffuse toxic goiter. It can also be called as diffuse toxic goiter. Why diffuse? Because you have diffused interpretation all over the thyroid gland. You don't see, the interpretation will not be at a particular foci. You will have a diffused all around the thyroid gland, all around the thyroid tissue. You have the abnormal interpretation. So that's why it's a diffuse toxic goiter. Now, what actually is a Graves? Graves is actually an autoimmune condition. What is meant by autoimmune? Autoimmune condition means the body produces antibodies against our very own cells or very own compounds present in our body, which are actually playing a physiological role. Actually, they are part of a body, but still body thinks like it is a foreign compound, and body secretes some, body produces some antibodies against those tissues or compounds. That is called as autoimmune disorder. Now, if autoimmune disorder is producing antibody against our very own body tissues, then what is Graves' autoimmune disorder? In Graves, there is an production of an antibody called LATS, LATS, long-acting thyroid stimulator. This antibody is released against thyroid stimulating hormone receptor. This antibody goes and acts on thyroid stimulating hormone receptor. Now, what happens if TSH receptor is activated? Then obviously TSH will be secreted. If TSH secreted, thyroid stimulating hormone secreted, what it will do? It helps in increasing the release of T3 and T4. So T3, T4 levels are elevated. Why? Because increased action of TSH. Why increased action of TSH? Due to increased action on TSH receptor. Why increased action on TSH receptor? Due to action of antibody LATS, long acting thyroid stimulator. Now this is all the mechanism. This long acting thyroid stimulator, it acts on TH receptor, and TH receptor further increases release of T3 and T4. Now, this Graves is also associated with HLA-B8 and DR3. HLA, human leukocyte antigen B8, as well as DR3. DR means depth receptor 3. It is actually significantly appears in the tumor origins. This DR3 receptor significantly appears in the tumor origins. Now, what are some of the features of Graves' disease? Some of the main features of Graves' disease are thyrotoxicosis. You observe thyrotoxicosis. Then you also see ophthalmopathy. Then there will be most undoubtedly you see this feature, that is exophthalmos. That means protrusion of eyes, protrusion of eyes anteriorly or forward. There will be a protrusion of eyes. There will be a protrusion of eyes. Eyes will come like this. There will be a protrusion of eyes. That is called a exophthalmos. Why there will be a protrusion of eyes? Due to collection of areolar tissue behind the eyeball. Due to collection of areolar tissue behind the eyeball. Right? Now there will also be one condition, that is dermopathy. What is dermopathy? Dermopathy is shown with a condition called pretibial myxedema. Remember, this is not an edema. Don't think like it is a type of edema. No, myxedema is not an edema. No. Pretibial myxedema means there will be deposition of glycosaminoglycans over the shin of tibia. See, this is a leg. This is a leg. Over the shin of tibia, there will be deposition of glycosaminoglycans. Glycosaminoglycans or the shin of tibia as well as dorsum of foot. For example, this is foot, dorsum, this side. Dorsum of foot, there will be deposition of glycosaminoglycans. That is called pretibial myxedema. And there will be one more condition, that is called acropathy. Acropathy means subperiosteal new bone formation, which is most prominently seen in metacarpals. More prominently seen in metacarpals. That is called acropathy, subperiosteal new bone formation. Okay. Okay. Now coming to the pathophysiology of Graves' disease. Coming to pathophysiology. Actually, no. What is normal physiology in thyroid? TSH acts on TSH receptor. This leads to increased release of T3, T4. This increased release of T3, T4 finally it inhibits the TSH. That is called feedback inhibitions. Previously we already discussed about types of homeostasis regulation. Feedback inhibition, upward regulation, downward regulation, we already discussed, right? So the increased release of T3, T4, they further start the cycle and they inhibit the further release of TSH, thyroid stimulating hormone. Actually, where are the thyroid receptors? Pharmacology we already discussed. Where are the thyroid receptors present? In nucleus or cytoplasm? Please comment down in the comment section. Thyroid receptors are present in the nucleus or cytoplasm. And I want to ask you one more thing. Are thyroid receptors or ion channel receptors or ligand gated receptors or enzymatic receptors or none of these? Which type of receptors? Please drop it down in the comment section. Are they ligand or ion channel or enzymatic or none of these? Please write it in the comment section. Okay. Now, generally it happens like this. TSH goes on TSH receptor. TSH receptor initiates the release of T3, T4. T3, T4 feedback inhibition of TSH. But in Graves, we already discussed there is an antibody, that is SLATs, long-acting thyroid stimulator. This initiates the TSH receptor and simply stimulates the TSH receptor. This TSH receptor, when stimulated, it leads to production of T3, T4 excessively. This increased release of T3, T4 further induces feedback inhibition of TSH, thereby causing to decreased levels of TSH. So what is the picture that you see in the thyroid function test when done in a Graves patient? If thyroid profile done in a Graves patient, what picture you will see? T3 increases, T4 increases, but TSH decreases. Why TSH is decreased? Due to feedback inhibition of T3 and T4. Okay, that is the mechanism. So this shows patient will obviously have hyperthyroidism. Hyperthyroidism, what it does to CNS? It increases the sympathetic stimulation. See, we already know thyroid function. What is thyroid function? It also regulates the neural system also. It has its part in neural system also. So if hyperthyroidism condition is seen, obviously it increases the sympathetic stimulations. Now what are the some of the features of sympathetic stimulation that you see? Tachycardia, tremors, tremors, palpitations. These all are features of sympathetic stimulation. Now we have two conditions that are observed here. One is hyperthyroidism and one is increased sympathetic stimulation due to hyperthyroidism. Now how will you manage or treat this patient? For hyperthyroidism, you simply give anti-thyroid drugs. For sympathetic stimulation increasing, you simply give sympatholytics or otherwise beta blocker. What is the drug you give in beta blocker? Propranolol. Which type of beta blocker it is? Non-selective beta blocker. Non-selective beta blocker. Now, previously we discussed hyperthyroidism causes sympathetic stimulation, but in females, this sympathetic stimulation produces some severe problems. Amenorrhea, increased risk of abortion. Guys, this is statement that will be given in NEET PG. Don't forget this statement. Increased risk of abortion. Don't blindly go for CMV, rubella. Don't think examiners will give this much simple options. You might even have thyroid anomalies also. So please read the question carefully. Don't try to be smart. Yes, you act smart, but don't try to be smart in front of examiner. Don't think like increased risk of abortion only CMV, rubella or other infections or any uterine anomalies. No, even thyroid will cause increased risk of abortion. Very, very important. I have seen hundreds of students, they never mark thyroid when I ask them questions regarding thyroid anomalies in pregnancy. Why they don't answer, I don't know. Why thyroid has done that a huge, did thyroid commit a huge mistake? Huh? Why you are not taking thyroid seriously regarding pregnancy? Very important, guys. Thyroid is very important in pregnancy. Don't neglect this. So many students are marking wrong answers. When they see increased risk of abortions, they simply go for CMV or rubella, or they simply go for what is that, toxoplasmic infections, or they simply go for uterine anomalies, or they simply go for ovarian anomalies. All these are nuisance, nonsense. These are. Thyroid is the prominent. Yes, diabetes also important. I'm not saying diabetes, hypertension are significantly important in pregnancy state, but thyroid holds its main key significance. And believe me, AIMS professors are very much fan favorite for thyroid anomalies in pregnancy. Trust me, trust me. So thyroid in females, hyperthyroidism in females, it leads to increased risk of abortions. And one more thing is infertility issues. Infertility. Now, what are some of the findings in grade? Yes, signs and symptoms in children. Yes, those are almost same like adults. Nothing much big difference. So you can just read it in the book. Not much important. Now coming to the findings in Graves' disease, what are the findings that you see in Graves' disease? Obviously, we already discussed there is a diffuse, Graves' disease also called as diffuse toxic void. Why diffuse? Almost the complete tissue is being affected. Now if the whole tissue is affected, obviously there will be an increased radioactive iodine uptake. Why? Because due to hyperactive gland. Due to hyperactive gland. Why hyperactive? There is an increased stimulation of TSH receptor. By whom? LATS. What is that LATS? Long acting thyroid stimulator. You revise, you revise, you recall, you remember. RRR. Right? Now, there will also be a hypervascularity. Right? But this hypervascularity, it is prominent at the poles of the thyroid, poles. Right? Now, this hypervascularity, they present the patient in front of you with palpable thrill, audible venous hum, and sometimes you can also observe audible brutes. This audible brute MCQ given in 2020 NEET PG session. Trust me, audible brute. And even in 2017 PG exam also it was given. In NIMHANS also it was given. Now understand the importance of thyroid. NIMHANS is exclusively for neuro, but in neuro exam also it was given with a thyroid question. See the importance of thyroid, right? Thyroid is very important topic. You revise. You leave colon, no problem. You leave appendix, no problem. You don't leave, never leave breast, never leave thyroid, never leave pancreas, never leave liver. These four are utmost important. 12 MCQs from these questions. 12. So, what's the investigation you do for the diagnosis? Obviously, FNAC is actually the investigation of choice for most of the thyroid disorders. But this is an autoimmune condition. Graves is an autoimmune condition. Now, can you do FNAC? No, it might not be that much helpful. Now, what you will do in this autoimmune condition? You will do autoantibodies. So, Graves, what is the single best investigation which confirms the diagnosis? The presence of LATS antibody, LATS antibody, long acting thyroid stimulator. That confirms the diagnosis of Graves. Now, what is the management of Graves? Obviously, we already discussed you have two main problems in patients with Graves. One is sympathetic stimulation and another one is hyperthyroidism. For sympathetic stimulation, you go with sympatholytics or beta blockers, that is propranolol, the very drug you use. And for hyperthyroidism, you go with anti-thyroid drugs, right? So while giving these anti-thyroid drugs, they actually control the symptoms in 2 weeks, but the thyroid comes to normal or something called euthyroid state in 6 weeks. You just remember this. Not so important, but you still remember. Symptoms can be controlled in 2 weeks and thyroid comes to normal state or also called euthyroid in 6 weeks. Right? Now, what are the most important anti-thyroid drugs that you use? Right? Most important anti-thyroid drugs are methimazole, carbimazole, propylthiouracil. Right? But remember one thing, anti-thyroid drugs, one of the most common side effect with most of the anti-thyroid drugs is they cause agranulocytosis. What are the cells designated as granulocytes? Neutrophils, eosinophils, basophils. What are agranulocytes? Monocytes, lymphocytes. Right? Monocytes and lymphocytes. Now, the side effect is agranulocytosis. Right? The side effect here causing is agranulocytosis. Right? So that is the most important side effect of anti-thyroid drug, agranulocytosis. Okay. Now, what are the three most common used drugs? Methimazole, carbimazole, and propylthiouracil. Now, these risks are very important. Why? You will not you will not be given with the word choanal atresia directly in the MCQ. No, you will not be given with this word. Trust me. See, I have given the statement, but that doesn't mean this word will be given in the MCQ. Not only myself, more even the today's NEET PG paper is like almost like AIMS. It's not almost like, it's almost equal to AIMS. So don't expect choanal atresia directly in the MCQ. No, 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 don't expect. You will get a question with the image showing choanal atresia. You might be given with the clinical features of choanal atresia, right? And you will be asked which drug causes this. In the options, you will be given methimazole, carbimazole, sodium valproate, and donepezil. What is the answer? Answer is simple. It's methimazole. Methimazole, it has one of the most serious teratogenic effects. That is the reason methimazole is strongly contraindicated in pregnancy. Remember, methimazole is strongly contraindicated in pregnancy. Very, very important. Very important. Now, what are the teratogenic side effects of methimazole? We will just read now. Methimazole, importantly, it causes the increased risk of choanal atresia. We already discussed, right? It causes increased risk of choanal atresia. Also, it causes increased risk of aplasia cutis. Aplasia cutis image I will give it in the session, as well as choanal atresia. Doctors, please don't panic, man. I'm saying one again and again and again, but in most of the times in the comments, so many doctors are saying, sir, please, this was not given, sir, that was not given, sir, this was not. Arey, chill, boss, chill, relax, chill. Take some beer, relax, sit, relax, enjoy the class. You just study this material first. I'm having the schedule right now. In the future, every subject is being designed as per the schedule. Images, just think of 1200 images. You have each and every topic immersed in this image. No topic will be missed from this image session. So 1200 images. Just cheer up, man. I have strong schedule designed for it. Okay. So choanal atresia and aplasia cutis, these are the increased risks caused due to methimazole. Carbimazole, yes, it also has some side effects, but not that prominent. But propyl thiouracil, it causes hepatic failure, hence it is highly contraindicated in females. Right? Now, finally, what is the treatment of choice for Graves' disease? Ultimately, it is total thyroidectomy. Why? Because it is diffuse condition. It's not a focal condition. It is diffuse condition. So, you can only do total thyroidectomy. Now, alternate option, if you ask, for example, in whom surgery is unsafe, you can go for radioactive iodine ablation. Radioactive iodine ablation. Okay. So with this, we will stop the class. In the next session, we will discuss rest of the things, and I hope we will just make our session a little bit faster. We will complete it as fast as possible. So don't get panicked. We will discuss each and every topic here. So until then, we'll just take rest and just revise your notes, and we'll just meet in after some time. Okay. Thank you very much. Your wise doctor.